your SVC is positioned at 12 o'clock. So for the LA projection, you just face it to you, and the RA projection, you just roll around. So you can see, I don't know what to show us up here. So there's your SVC at the top. So SVC is up here, okay? Aorta's there, mitral valve is here, and on the LA projection, we have SVC there, aortic valves here, and you can see the fossa and that dropout, and the tricuspid valves down there. So we'll look at lots of those in a second. So from your pathology, I'm sure you all know this, but this is how my orientation is going to be, so that when my interventionists do their work, they know exactly what I'm actually showing them, because they know my orientation is the same way every single time. And I think interesting is this red box here showing that LA view with that patient, the first case that we had today. She had a PFO, it was actually joined onto this ASD, so ASD came off here, so this was all deficient in her case. And I have one, I think my fourth case, is very, very similar. So these are the projections we just talked about. So make sure you know which view you're looking at. But always, if you look at my pictures, we'll have the aortic valve from the LA projection at around 9 o'clock. Okay. Whereas in the SVC view, it'll be up at the top, and your aortic projection will be the opposite. So what's also very important is the terminologies when we talk to our interventionists. So simple thing is aorta is anterior, and then opposite of that is posterior, superior is SVC, because it starts with S, and inferior is IVC, which starts with I. So we sort of mention the same language, everyone is saying the same things when we're actually talking about things. And that's why the orientation is so important. When we talked about our rims, you probably had this earlier today, from the RA projection, you can see the aortic valve, AV valve, or the tricuspid valve, posteriorly and SVC, and no concern regarding whether you have deficient rims or not. And then from the LA projection, you have your torus, which is between your mitral and your aortic valve, mitral, and your right upper limb veins. So as long as we know which rims we're talking about, it's really important for us to concentrate on this. Now, okay, atrial septal defects. So I think everyone here looks at all the congenital patients, so the primum and secundum defects. It's very important not to miss the venous septation defects that can sometimes accompany these things as well, SVC, IVC, and ungrooved coronary sinuses. And because I deal completely in adults, we actually see quite a lot of acquired ASDs as well, patients that have had procedures done, they've now got a device. One was a transplant patient who actually during her biopsy, they perforated through the atrial septum. We've had ECMO cannulas pushed in the inferior part of the wall. And then the other thing to remember is, as the doctors talked about earlier today, this is a lifetime disease. So if you close a septum at the age 4, by the time a man's 6'7" and 40 years old, the patch may not fit anymore. So you can sort of dehiss away from the patch and you can get an inferior defect. So these are things to remember, that they're not just a closed and done and dusted procedure. Okay, so when we do our septum assessments, we look at the location, the shape, the size, and we do 3D and balloon sizing for most of our cases, and except the very straightforward ones. We look at the rims, if there are aneurysms or penetrations, and then the flow direction. So I think you had all this discussion this morning already. This is pictures are from Dr. Vegas' book, Perioperative 2D Echo. It's an excellent book. If you haven't got that already, you can purchase it through University of Toronto site. It's a great pocket handbook to have in your guide. Now, when at Prince Charles, we do an assessment sheet for all our structural cases, and we have one specifically for ASD defects. It talks about the rims, feasibility, and potential complications. And what we actually get to do is look at our fellows who draw this picture. They have to draw this picture out for me and draw the defect in there, name all the rims, so that when we go and do our procedure, everyone is actually on board already and we know exactly what we're getting into. We'll double check all the rims and everything on the day and make sure that nothing else has changed or missed, but you need to be able to do that. So first case, 48-year-old lady presented with dizziness, and she had an echo that showed mildly-dilated RV, normal LV, a large secundum ASD with left to right shunting, satisfactory valve function. She obviously went through right and left heart caths, we do in all our hospitals, cases that we see, and she had her typical 2D assessment. So you've already been through this. I'm not going to go through all the different rims and things on 2D again for you, but it's very important. We do all 2D assessment and we do 3D assessment, so we don't do just one and not the other. So we've done our assessment, so this is our drawing that the fellows have done and generated all the different rims, and beside all that they'll actually have the number of what the rims are, so I know exactly what we're actually getting into, what the defect is. Okay, so how do you do 3D assessment? So the important thing, the first tip is you have to orientate your picture the way your interventionists like it. So I always orientate my small blue box on the top left as my bicable view, so SVC, as you can see the coronary sinus there. Now, our interventionists don't like the aorta on that side, they want the aorta on the other side because they're used to the 60-degree view, so I will change my picture by changing that bottom rotate red line. If I rotate it down the bottom, it takes my aorta to the other side. Okay, so that's exactly what I just mentioned. So you're getting your orientation right. Now I want to rotate everything to be aligned. So I'm a bit fanatical about straightness. Everybody that talks to me is like, so I want my green plane, red plane, blue plane, everything to be perfectly aligned in terms of upright. Okay. Now I also want my 3D plane and my blue plane to be rolled exactly the same way. And you can see on that Phillips button I've pressed blue and rotate, and that matches your blue plane with the 3D plane. So we are now ready to start. So this has taken all this time to get it all laid out and set, so everyone now knows what we're getting into. Okay? And every time you look at a case, you'll know exactly, if you walk in any time, you'll know exactly where we are. There's no surprises. The other thing you can do is you can adjust it so that you have a 3-to-1 projection if you wish, which means you can make one plane bigger than the others, because some of the interventional screens are actually quite small for echo, and so if you use the little tiny screens, it's very hard for the interventionists to see what's going on. More so for the MitraClips and TriClips, which I think we talk about tomorrow. I'm not sure if any of you are coming to the Congress tomorrow. So we can orientate it to which way you would want. The other thing you can do is you can actually flip crop. I don't know if any of you used flip crop before. Flip crop is a little button next to your reference plane. It's basically cropping or showing the picture where that white line is. So it's taking the right line from above, which is the LA view, to the below, which is the RA view. So you can now look at the septal defect from the other view as well. Just a little reminder, this is obviously not the patient, this is a normal patient, but when we're talking about orientation, superior and inferiorly, I just wanted to stress that we talk about the same things, but the main thing I wanted to show there is posteriorly, the back of the heart, is where Waterson's groove, which is what that WG stands for. That's an area that is a bad spot for any sort of rupture or tearing. So you've got to make sure that you check that. We always check the Waterson's groove in our pre-procedure toe, especially for septal crossings and things like that, that there's no effusion of fluid there before you get started. Okay, so you can also change it to all the other views as well. So when you're in NPR, you have those 3 little ones to a big one, and the green for me is set up so that's my bicable. The red is set up so that's my aortic view or the 60-degree view. Okay, so if the interventionists want to have a closer look at something, I can change the views to whichever one they'd like. You can see that white dotted line now is above the valve, so now I'm looking, that 3D is actually looking from the LA view. Okay. If I go too fast or anything, just let me know, because I get a bit excited and talk too fast sometimes. So, from these views, I do my rims and my sizing. Okay, so we can then interrogate the lesion, not just by our fixed images, but we can roll carefully through our blue plane and check the rims really closely to make sure the shape's not funny. Because you'll find a lot of times you do your sizing from your proper views, your 100-degree and 60-degree view, but then when you do your sizing, the size is different. That's because the shape's funny. Just like the case this morning, it was a teardrop, sort of a funny shape, and so where we were measuring wasn't the maximum and minimum size, but 3D on face allows you to get there. So now we're measuring the size of the ASD itself. The other thing is when you get the next stage of upgrade, there is actually a 3D auto left atrial appendage sizing. You can cheat the machine. The machine doesn't know. Any hole's a hole. It'll measure it for you. So you can actually use and activate your 3D auto LAA, and it will give you perfect maximum minimum dimensions in your area as well. So I think some of you may already have that on your machines. I'm not sure. But obviously it says LAA, so it's not ALA, it's ASD. Now, the other thing to remember is always interrogate all the other ribs. So don't just look at your ASD. Also, move your box up to the top, check your sinus venosus rim, and you can see it from both planes. Push it down below, check your IVC rims, coronary sinus rims, and make sure that you haven't missed anything. So don't just think that that one hole is it. You don't have to worry about anything else. So this is actually that patient. This is written by one of my fellows. So he's drawn a little picture. They said they got sick of drawing the picture. So we now let them have a printed picture, which they've actually originally drawn in the past. So it draws the shape of it, tells me all the rims and the area and the size and everything. So pre-procedurally, when we have our meetings, we've already decided potentially what size defect we've got, what we're going to be doing, and how we're going to approach it. So in summary, this is how we would lay it all out. These are the things, obviously not as pretty as this, but written down in terms of the size, what drugs are deficient, is there any problems with aneurysms or fenestrations. That's all listed on a sheet. We give them what the QPQS is, and they'll put their cath results and everything on there as well. So hopefully we don't go into there and get a surprise. Why do we do this? Because we've had surprises and we don't like surprises. So sometimes you do have a case that's not the same one, that the defect's actually too large. This is a patient that has pretty deficient rims, or a large amount of deficient rims, and we wouldn't tackle this sort of patient. Surgery is great. You can even do mini approach. Patients can get fixed properly with no concerns for the rest of their lives, having rubbing or erosions or anything, so we prefer that. Okay, second patient. So this is a 35-year-old guy, came in with atrial fibrillation, and when he had his toe cardioversion, found that he actually had an ASD. So his ASD was a bit tricky. You can see there from the two views that it was aneurysmal, fenestrated, and you see he's got a little PFO as well. Just there, oopsie, there. Okay. So quite a complex defect. And then on 3D you can see quite clearly, so orientation exactly as you know, aortic valve there, PFO there, ASD there. Okay. And then when you look at it from the side, you can see quite clearly the PFO is coming up there, and you got this, not the whole thing is actually deficient, it's just these fenestrated funny bits that are coming off there. So then we use sizing to determine. So this case, you can't size it easily without using 3D interrogation, because the jets are not in the same plane as your septum, not like a normal hole. So we actually spend quite a bit of time. Now I'm just going to flip that picture around for a second, because most of my pictures, even though my 3D pictures are all LA side, when we do our drawing, we've got to make sure that we've actually drawn the right side, because that can sometimes get a bit confusing. But tip number 2 is, with these complex cases, we should always try and use 3D to check your size. So activate your multi-view, like we did before. Make all your alignments perfect, like we did before. And then choose which display you want to have. Okay, and we actually put the color on. So just like the case we did this morning, we actually had color on, and we were actually sizing with color, and that's the reason. Fossa drops out, you can't be sure. If you measure it without color, you could be measuring thin tissue and not actually the true defect. But this defect, even in my planes, you can see here, is not in line with it. So my plane needs to be like this to be in line properly. And even here, I'm off. I'm perfect for the septum, but I'm not perfect for the defect. So I've rearranged everything, and I've aligned it now to the defect. Okay, so now I can measure it properly and tell them what size I think it is. So in summary sheet, just like we would have done for the first patient, we would tell them what we think it is, what our concerns are. It's aneurysmal, it's got sufficient rims, the size of what it is, and that it's a complex lesion. So we did tackle this one. So how do we tackle this one? We tackled it by putting two wires up, one through the PFO, one across the ASD, and decided to close the ASD first, use it as a platform, and then close the PFO afterwards. So this is tracking through from the yellow all the way around. So you can see the ASD device coming across, down on the septum. This is a Gore. I don't think you have guys at Gores here, but this is a 30mm Gore device that we used in 2 in tandem and slowly pulled it down. Once we had it in place, the 3D picture, we then started deploying the PFO device. And you can see here coming down nicely, 3D on face view. So you can still get quite nice pictures in 3D on face because you can then make sure that there's no interruption or problems in terms of your device coming down. So often we'll actually do on this, and you can sometimes see it better on 3D like this than on your 2D X-plane because the angle which you're seeing it is actually perpendicular to your X-plane beam, so you really can't see things as well, but sometimes on live 3D or 3D on face view you can see it nicely. So in the end we had 2 tandem devices which are side by side, looking very nice and tidy, and no concerns regarding erosion. Everything was closed properly. We weren't 100% sure because it's all this interference from our device, whether there was any concerns regarding the flow between it. So you can see here very nicely 2 devices side by side. So we do occasionally do saline bubble studies afterwards to ensure that there's no shunts remaining. And this is, although the shadowing from the devices makes it hard for you to see the bubbles, I hear the bubbles coming in now. There was no bubbles leaking through the device. Sometimes before there's endothelialization, you may see a few little bubbles, but that's normal. Just to be fair for other companies, I thought I'd just put this picture up. And Platzer, which I think you guys are very familiar with, the Occutech and the Gore device. So we have access to all 3, which is great. So we have a choice in terms of which ones we want. But it's important to know from our perspective, from a 3D perspective, what the devices look like, how they open and deploy properly, because the Amplatzer and the Gore are very different to the way you actually approach your deployment. So you need to be aware what your interventions are doing and communicating closely with them regarding what's going on. Even though I sometimes want to do certain things, I'll do whatever they want. So if they want something, I'll give them that picture. Okay, 4th case. I think this is the one that looks very much like Our Lady this morning. So this is a guy, he had COVID, and so he had a transthoracic just like everyone does, and was found to have a dilated right heart. And then he had an MRI and showed a small to medium ASD with no other defects. So you can see here the middle view is just the rolling view. I just roll it backwards and forwards so you can see what's going on, but it's a very slither-like, narrow defect right on the edge there. Very similar to Our Lady this morning. So because the shape of it was a little bit unusual, we tried to use 3D MPR to actually interrogate this defect a lot better. Okay, you can see here on color, it was a bit hard to actually assess what was going on there, but we always use color. Just drop out on your fossa, you can really mismeasure everything if you don't use color. You can make things a lot bigger than you truly are, and then you get yourself in trouble. So we use color 3D like we did this morning to measure the size better. Sometimes I use the color and then I hide the color and then measure it from there too. The picture's nice, but in this case we measured it here. We also use balloon sizing like we did this morning. What I try to do is sometimes I can't do my MPR straight away. So when they've got the balloon up, I just do a quick 3D. Okay, then I do my 2D X-plane, but I've got my 3D there. I go back. This is before alignment, so I haven't actually aligned my picture perfectly yet to my waist, the balloon, so you can see the waist really well on the 3D. So then we've done X-plane just like we normally would. That's fine because I've got plenty of time. I can measure this as well, like a traditional way. But then I went back to my 3D and MPR that 3D balloon and got the sizing better on that. And from before sizing to after, we changed from 27mm Gore, because it was a 14mm size. We upsized it we said the defect was more 19mm, so upsized it to 37mm. So it's actually very important in a lot of these cases to size them properly. But you don't have to do your NPR straight away, because sometimes fiddling around like that, the intervention's like, well, guys, we want to deflate our balloon, just like today, right? They said they didn't want to wait any longer, so we just acquire the picture and then we go back and do it. So here we are, we went back and we crossed. Some of my interventions like to have it done in 3D multi-view, which we can do as well, but some of them prefer, as in this case here, we actually deployed the Gore device with 2D, and you can see here it's very different to your Amplatz device that you use, the Amplatz device that you were using today. We put the device right up against the septum, when everything is right down nicely, then the RA side is deployed, and it's a very much more controlled and slower process than what the Amplatz device is. This is what it looks like. So it looks very different to the other device. We then do our interrogation just like you do in 2D, but we also do it in 3D as well. So we do both interrogations, not just the one. Now, the other thing to comment on is that the RA side of the device, often you can't see it very well at all, but there are some tricks you can do to try and see it better. Obviously this machine, we talked about flip crop, so you can flip it around and have a look at it, but sometimes it doesn't show very well. You can try and go quite distal inferiorly. Sometimes it will actually straighten out the septum and you can see the RA side. The other thing to keep in mind is always that deep transgastric view, the 4-chamber. You can actually see the RA side of the device from that side, and sometimes it's good enough to even 3D from that side. So it's always worth practicing doing that. So if you practice doing it every time, one day when they say, I can't see the RA side, I need to see what's going on, then you know exactly what to do and how to get those images for them. So we try to do this for all our cases. We actually look at the LA side, we look at the RA side, and then if we're happy with it all, you can see this one's not detached yet, so they haven't actually taken it off, and then we'll detach it. So this is just an interest thing. This has nothing to do with the cases you looked at today, but I just wanted to show you that it's actually quite tricky sometimes, even on 3D. So this was a patient that they tried multiple times. You'll see this video flicking through it multiple times. They're trying to get this Gore device down onto the septum. And every time they go down to the septum, something is holding it up like a flower, being held up like a flower petal. So I don't know if you get the idea that there's sort of flickery stuff all in front of us. So this patient actually had some sort of webbing in the LA that was distorting the device. And the device never ever came down properly onto the septum. But you couldn't see it on 2D, and you could just see it maybe on 3D, but definitely the shape of the device told you that something was holding it all up. It wasn't actually, see how it's just curled up in the sky? It wasn't actually letting the whole device come down. So there are some unusual things that can happen as well. So that's my tips for things. So 3D, so interrogate your septum. Make sure your orientation is right. I think that's the key thing to everything. If you have your orientation perfect, then you can actually, talk together with your interventionists and they know exactly what they're looking at. And then acquire your 3D if you can't do your NPR straight away. Any questions?
Any questions? So we are